In our next session, we're going to be discussing the capacity conundrum, building and buying for what may or may not come. We're going to discuss how Stanford and Rambam are managing projections of critical infrastructure and equipment needs under an uncertain environment without losing sight of costs and disruption. First speaking will be Rudy Arthofer. He is the Associate Chief Nursing Officer for Stanford Healthcare and was responsible for coordinating the build out of our campus in response to the COVID-19 crisis. After that, we will be hearing from Dr. Hani Bahuth, who's the Director of Trauma and Emergency General Surgery and the Medical Director of the Teaching Center for Trauma Systems, Emergency, and MCS at the Rambam Healthcare Campus. From Nira Huja, she is the physician and clinical professor and the Division Chief of Hospital Medicine and the Medical Director of General Inpatient Medicine here at Stanford University. And finally, Christina Kong, who's the Vice Chair of Clinical Affairs and a Professor of Pathology at Stanford University. Rudy?
All right, thank you very much. I have one slide to go over. And we're gonna kind of break this up into three parts. I think I have about 5 to 6 minutes. We'll go fairly quickly. Section here on really the capacity for space and looking at patients' placement space. We have some key resources, key equipment, and then some just quick discussion or information on how we really developed a system for tracking and understanding where we stand with certain volumes and triggers. Each of these columns represents a series of task force groups of people that were involved in developing each of the different sets of work. The first one that we started off with, once we understood and started to realize what was coming our way, or potentially coming our way, was to really understand, okay, we're not looking at staffing ratios, we're looking at sheer space. And this is the potential scenario where we are just unable to control enough of the intakes coming in to maintain some of our normal aspects of work. And so we had to look at our facility in a very different way. And it led to the first question that we had to tackle. Do we outfit the kind of quote unquote the mothership, the central area, or do we start to develop these kind of exterior facilities where we could bring additional patients? So we have a wonderful facility up the road, 20 minutes, where that we could outfit for possibly even, depending on the scenario, some fairly sick patients. As an institution, we had to make a decision on that point because what we found is that we're much less efficient, and we're probably much less efficient with the key resource, which was staff. So at that point, very quickly within the organization, we said, we need to absolutely maximize the central area, bring staff, bring equipment, supplies to that central spot and utilize that because we'll be able we won't be transporting patients around. We won't have to worry about the management of vents and other key resources. So with that principle, we quickly went into looking at the facility, we'll call it 800P, not only the current inpatient beds, looking at what could the interventional platform be turned into. We've had a lot of the discussions about that theoretically in the design of the building. We were very lucky in having 500P, which is an additional 300 beds plus interventional 20, 30 interventional platform just open. So we'll consider that lucky. We looked at how we could go through and what types of spaces the interventional platform would be good for, including the actual ORs in actually losing some of the red line. And then from there, looking at actually the space that we had just shut down. So we were going to be utilizing a group of units to renovate, and the decision was made to put that on hold. So we were able to go from roughly about a 600 bed facility to pretty quickly upwards around 1,000. Key point here, which was pointed out very frequently in the discussions of this wasn't staffing, this was space. And each of the beds that we were opening, whether we were looking at it in an atrium or an ICU, we were labeling what types of patients could be there so that the people placing patients at the time were aware of what the types of space they had available for and the types of patients that they could manage in those spots. So this was a new aspect. The second piece that was obviously readily came apparent was there's certain high risk resources. This isn't supplies. Amanda will talk about the supply piece in a separate part, but this is looking at like physician teams, nursing staffing, Obviously, the bed capability, ventilators, we all know, became a very hot topic very quickly. So there were task forces that were set up to go through and, one, get a true count of where we currently are. It's surprisingly difficult to understand just exactly how many ventilators we have at any one point in time. And then develop a system or a process to make sure that we can understand where we stand at any given moment. And then obviously the intake of additional pieces of equipment. And then finally, there was a series of groups that were put together to look at tracking each of these key resources in real time. And I have to say, I'm not advertising Epic, but they did a really good job working with us to develop dashboards that we had real-time data streaming into that helped us understand where we were with the ventilators, where we were with CRRT, ECMO, things of that nature, and that we could then correlate that to what triggers we said, okay, if we reach this level, we need to bring in additional resources from the warehouse, things along those lines. And we also had similar systems with tracking the volume of COVID positive patients in hospitals in our county and things along those lines. So these sets of task forces, not in a hierarchical way, but in a more of a reporting way, reported up to the kind of fourth piece of this puzzle, which was the Interdisciplinary Surge Committee, which met every day at 7 o'clock in the morning, 7 days a week. And just the key piece here was just making sure all the different groups understood what was going on with the other groups. And so where there was a lot of silos developing their processes, this helped everybody have a very brief conversation, 15 to 30 minutes each morning, to understand where roadblocks were coming up. And then this group was one of the many groups that reported into court, which was the organization hierarchy that was developed very quickly, that had representatives of the dean, the CEO, obviously the university chairs, things of that nature. So a very quick decision-making group that could deal with issues as they came up overall. So I think that's my time. I want to be cognizant of everybody else, but this is a brief overview of our process.
Thank you so much, Rudy. And next we will hear from Dr. Hani Bahuth from Rambam Healthcare. Dr. Bahouth.
Okay, so good evening from Haifa, good morning in the States. So this will be about the hospital surge capacity calculations. I am a surgeon, and everything will be much easier for me and for us as surgeons to have maybe numbers in the situations that we need in a very short time, additional resources that we can measure and we can calculate in situations of emergencies, in disasters as a general situation. So the three essential components of any disaster is the personnel, how many equipments and the supplies we need, and is about the structure of every hospital. The numbers that I'm gonna share here with you is about percentages that can be calculated in any situation in any hospital, because this is percentages and not fixed numbers as you will see in this presentation. It is very important that in the surge capacity in any hospital, this is a situation of one point in any time, okay? That can be calculated, and after that we can also follow it up in main three sites in any disaster, means that we can see that in the emergency room, in the ICU beds, and in our operating rooms. It is very important to see the severity of the situation, the acuity, and the duration. Here we have two different situations. The first one is a very short dramatic event, and you can see here that the time is very short to have the response. And here, this is an extended event like in the COVID-19, that we can see that our response can be in a long time, days and weeks and months and so on. Here we have a little bit more problematic situation, because our reaction and our response need to be very, very short, and all the hospital, especially the emergency room, operating room, and the ICU's beds need to be in very short availability. The assumption is very, as I said, that the basic assumption that this hospital surge capacity need to be on the top of a situation that all the hospital is with full capacity. And on the top of this full capacity, we need to calculate and we need to add our needs for the response. It is about the maximum number of the additional beds that we can treat, the additional number of the patients, and the critical equipment and supplies. The number that is the percentage, this is not the number, the percentage of the maximum number of the patient that is very accepted in all around the world is about the 20%. Means 20% of the total bed capacity of our hospital. Like, for example, if you have a hospital with 500 beds, 20% of our patients will be a critical one, mean like severely injured in a critical patients. Pediatrics, especially in mass casualties, will be 20%, and the patients that will come with anxiety will be around the 30%. So in a 500 licensed bed hospital, this hospital will need to face and confront a situation of 20 critical patients that need to be treated in a very short time. Here you can see the situation of red means critical patient, or here the moderately injured or a hospitalized patient, and the green, these patients or injured patient will be lightly injured or and very simply injured. Here, what is the table here is about everything here is about the numbers, and what we can see here is about the personnel needed to take care of that situation. Everything is written here about the triage, the attendings, the physicians and the nurses and therapists and the radiology technicians and so on. It is very well designed table to know exactly the needs for this situation. And by these calculations, very simple calculations, we can plan our response in situations of sudden mass casualty, like disasters in any kind, or if this is an extended event. For example, 500 beds hospitals, in the beginning, like in the first 2 hours, we will need 20 doctors, 20 nurses, 10 clerks, the therapists, 2 blood bank technicians, and so on. Means that if we have this number, very simple numbers of the hospital bed number, and the 20% of those beds on the top of the situation of full occupancy of our hospital. So by this we can calculate in any time the personnel that will be needed to cope with the situation, and also the supplies and the equipment that will be needed. About the operating rooms, it is very important how we can evacuate our operating rooms. 10% of the severely injured patient will need the urgent operations. Mean if this is a 10%, it will be from the 500, from the 20%, we will need 2 patients will need like a life-saving surgery. Means that we will need 2 operating rooms immediately in these situations. This is one for neurosurgery, the other one will be needed for bleeding that needed to be stopped in the in the operating room, and we will need a trauma surgeon and neurosurgical team, 1 trauma team and 1 neurosurgical team. Surgical interventions. After that, not an urgent emergent situation, but urgent situation also can be calculated, as you can see here, the open fractures and so on, but not in the first hours. It can be delayed for a couple of hours after that. These are the equipment and the supplies. Okay, everything is detailed here. Also, based upon the 20% of the number of the beds of that hospital, and everything can be calculated. And by that, by that, we can plan our response. It is very important that in this situation, we need just to separate between the critical patients and the moderately injured or situation patients, and also for mildly injured or mildly medical patients. So by this 20%, everything can be calculated, if everything can be prepared, and our planning in any hospital can be planned and prepared if we know the number and we know the importance of the term of the hospital surge capacity as it's accepted today, with the around 20% of the total number of the beds. It can be used in a situation of war or situation of disasters, in situation of any other medical situations, and by this we can be in better planning and preparedness. Thank you so much.
And thank you so much, Dr. Bahouth. Next, we will hear from Dr. Nira Huja from Stanford Healthcare.
Thank you, Mark. And as I share my screen, I just wanted to thank Courtney and Kelsey for all of their help in coordinating this event. My name is Nira Huja, and I'm the medical director for general medicine, which was the hospital wards. And these were the sites that the patients who didn't go to the ICU were admitted to. And following Rudy Arthofer's talk, there was definitely a lot of planning that went into this, because we weren't sure what we were in for. We were watching the numbers on the East Coast. We were worried that as we saw our own numbers go up, we needed to be 2 steps ahead just to anticipate the worst case scenario. And what I'm really, really happy to say is, as we looked across the institution for faculty who could help us staff the wards should we encounter the mass numbers that the East Coast was saying, people raised their hands to no end. People from other departments, ENT, had board certified internists that were ready to volunteer. Vascular surgeons had the same. It was just so great to see the camaraderie and the tight-knit collegiality that came forth during this crisis. Now, about 20% of our patients made a detour to the ICU, but then they would come back to the wards. And what we needed to do was first ensure that we were utilizing PPE properly. And there was actually a lot of anxiety around this, because before the rules were fully established, infection control had one set of protocols which were guideline based, but the providers felt like all the patients in the room should also be wearing a mask. And that wasn't one of the initial recommendations. There was also concern that, are we going to overutilize masks if we have, all the patients wearing masks, all the providers wearing masks, et cetera. That did end up being one of the rules, and it still is today. And I think it's contributed to our low provider transmission rate and low overall COVID contraction amongst our hospital, just because of adequate PPE supply and appropriate use. As you can see here, at its peak in our institution, COVID only reached about 30% of our total volume within the general medicine service. But because at times, we have actually on all of our general medicine wards, we have house staff. We decided that we consider the house staff, these are the residents, the interns, et cetera, a vulnerable population. And we said, we don't want them to enter the room of these COVID patients. So that did put a little extra burden on the faculty. They were the forward-facing frontline folks. But we had something called a Zoom room, which was an iPad in the patient's room connected to a monitor at one of the nurses' station areas. So house staff and providers could still communicate with the patients if a physical exam repeatedly was not necessary. So that conserved PPE and still optimized patient communication. I wanted to just show you that these were just some of the statistics in our institution. The average length of stay of most of our COVID patients, if they did not go to the ICU, was just over 4 days. However, if they did go to the ICU, it usually happened in the first 48 hours, and the length of stay was just over 2 weeks. Now, as most institutions did, we developed a workflow, which you heard in detail from Rudy, just a few minutes ago. But I wanted to also highlight that the availability of testing, which was so helpful, and we had rapid tests available, and Dr. Kong will talk more about that, really made our care of these patients helpful, and the shortages were very few and far between, as you'll shortly hear. Because we're an academic medical center, we were very rigorously involved with clinical trials. And, Act 1, which is the NIH trial looking at remdesivir back in March, was one of the, big trials that we were enrolling in. And we found that we had other hospitals in the surrounding areas asking to transfer their patients to our hospital. And it was in part because of the potential optics of resources that we had as a large academic institution. So we created a multidisciplinary task force to look at how to address this. And the goal was to help our community, help our surrounding patients in hospitals, but in a way that balanced the resources and was safe, both to the transport team and to make sure that we were transporting patients that we really felt we could benefit. We have a transfer center, and actually Rudy, Arthofer, and Dr. Steve Ruas help oversee that. And they were the gatekeeper. And we had a set of criteria, such as if the patient had COVID for more than 2 weeks or so, we knew that at that time remdesivir wasn't likely to benefit them. What is the other opportunity that we could help them with? Would it be higher level of care? Would it be support of their other chronic medical problems, et cetera? So each patient was very thoughtfully and thoroughly considered as we weighed our options to accept patients from surrounding areas. And we did accept quite a few patients. We wanted to obviously protect our emergency department, so we would try to admit them as direct admits whenever possible. And then finally, I think that we came out of this because of all of the planning, work, and learning that we had from other institutions. I hope that we don't hit another surge, but if we do again, we will be prepared. Thank you very much for your time.
And thank you so much, Neera, for that. And finally, we'll hear from Dr. Christina Kong from the Department of Pathology.
Thank you. So I am the medical director of pathology and clinical labs. So I oversee the areas that do all of the COVID testing. We're fortunate that Ben Pinsky, our director of virology, is always keeping his eye out for the latest virus that's coming out and for potential pandemics. So when there is a new virus in circulation, whenever the sequence becomes available, he actually starts validating a PCR test so that there is availability of testing in case it's needed. So as soon as the SARS-CoV-2 sequence was published in mid-January, he started developing a test. And by early February, we had a SARS-CoV-2 RT-PCR that was ready for use. And it wasn't until the end of February that the FDA relaxed restrictions on SARS-CoV testing that was outside of the CDC. And so as soon as it was relaxed, we put in an application and were able to start testing a few days later based on an FDA EUA. One of the concerns during this time, with the testing was the potential for false negatives. Since there were limited numbers of N95 masks, they could only be used in certain clinical situations. So if patients were negative, they were in areas where people were not using masks. And so we received a lot of questions about what is the sensitivity of our FDA EUA assay. Since this was a new virus, there is no gold standard for testing. And so the only way we could kind of get at that question was to look at repeat NP swab testing within 7 days. And we used that as a surrogate gold standard. We found an overall discrepancy rate of about 3%. University of Washington found a similar rate. And so we estimated our sensitivity to be about 97%. Having said that, there were reports in the news of multiple facilities where there were higher false negative rates. And that actually just points out that the proper collection of specimens is the most important step in the lab diagnosis of infectious diseases. And so there was a shortage of nasopharyngeal swabs, shortage of transport media, and with the shortage of N95 masks, sometimes the collection was not properly done. We were fortunate to have an extraordinarily strong supply chain. So we were able to maintain supplies of the NP swabs. we started making our own transport media vials by just using buffered saline. And by prioritizing testing, we were able to just continue using the highest sensitivity assay possible. So we were able to use the RT-PCR assay performed on a healthcare worker collected nasopharyngeal swab throughout the pandemic. And so we did not have to switch to other specimen types. There are variables that really do impact testing quality. Who collects a sample, whether it's healthcare worker collected or self-collected. The collection device used, nasopharyngeal is the most sensitive. And then there's mid-turbinate, nares, and saliva. And then also the test method. So there are a lot of different assays out there, and there's also the potential for doing pooled testing. All of these options are viable for testing, but it's important to understand what the impact is to the sensitivity of the assay. And so you may choose to use a test that is more comfortable, easier to collect in an asymptomatic population. But for inpatients, it's important to have the highest sensitivity test so that you're not cohorting individuals who may have false negatives. And of course, if you increase testing frequency, that is another way to compensate for decreased sensitivity. So as I mentioned, the type of test also can impact the sensitivity. With the limits of supply chain, and especially with the different test kits, we thought it was important to have multiple platforms available. Our goal was to have 3 platforms for each type of testing. And so when the rapid test came on the market, we evaluated 3 different rapid tests. We found that the Cepheid Gene Expert had 99% positive percent agreement with our routine RT-PCR assay. And so that one worked really well and we implemented it. When we evaluated the Abbott ID Now and the Mesa Acula, we found that the positive percent agreement was not high enough to meet our standards. And so we chose not to implement these assays. We did not want people to have questions about, what assay was used? Is it sensitive enough? Should I trust it? So we made sure that every assay that we performed at Stanford was similar in terms of sensitivity. And that way people could be assured that we were providing the highest type of testing possible. And then from early on, we set a goal of being able to do 20,000 PCR tests per day. And so that's what we've been driving towards. And that's by bringing up different platforms, as well as implementing pooled testing in pools of 4. And now we've also moved on to developing an at-home collection kit in partnership with CZ BioHub. And that one will allow us to increase access to testing. And then, of course, with vaccines coming into play, serology testing is another test that we have available, and that will become more important in the future. One thing that I want to comment on also is that throughout all of this, dissemination of information has been one of the greatest challenges. And so reassuring people about the performance qualities of our tests, trying to get that out through memos, town halls, grand rounds, and just talking to people so that they have the information has been one of the biggest challenges throughout the pandemic. So I will stop there and hand it back to Mark. Thank you.
Thank you so much, Christina, and thanks all of you. So for the next 10 minutes, we will have a little bit of a discussion about the issues that have been brought up during this session. One question I had for Dr. Bahouth is that certainly in the United States and certainly in most urban areas, hospitals run often in excess of capacity during normal times. So we had the unusual situation where we had just recently built a new hospital and so had certainly capacity in physical space available to us in order to build out our capacity. How in Israel is the challenge of excess of, frankly, overcapacity managed in a general sense versus the United States, where we have economic reasons to keep our capacity low?
This is, this question is very important one on these situations. I think that most of the hospitals today are facing this problem of the overcapacity. And the question will come is that how we will manage it. Well, like in Rambam, when we have here something like 1,000 beds and the emergency room, most of the time is with full capacity. How can I manage in a very short time more 200 like injured patients or casualties? Okay, there are many theories and we have many protocols for this, and this is what we are trying all the time in. Like to share this knowledge, how to cope with this situation, how we can empty our emergency room, empty our ICU, make like 2 or 3 rooms in the operating rooms that they are available in very, very short time. Like we'll start from the operating room. From the operating room, the average time to have very urgent or emergent room in the OR is about 7 to 8 minutes. This is a very reasonable time between the cases, the elective cases that we are doing in the operating room. About the emergency room, that this is the most sensitive area and site to manage these situations. We have protocols. How to evacuate our emergency room step by step. Who will do this? Where to? How we to discharge patients to other departments or the other wards into the hospitals, and to evacuate at least 80% of the emergency room in very short time. Means between the average time is 15 minutes, 15 to 20 minutes to evacuate most of the beds into our emergency room. We talked about it a lot when we visited Stanford before 2 years already, and we are doing this in many other countries. This is not the time to do to go step by step how we would do it. But I think that the most important issue is about the protocol and how to drill these protocols to evacuate your emergency room and to have very high number of patients in half an hour and how to deal with it.
Thank you so much.
The key point is the protocols and drill the protocols, not to have the protocols in the closet and nobody knows what to do in real time.
It is so true how important frequent exercises and drilling is when the event actually strikes. Rudy, I remember that we were having issues, even though we had physical space. Can you talk about some of the challenges we had, especially with things like the ventilation system in some of the older parts of our hospital campus, some of which were built in the late 50s?
Yeah, there was, we kind of got lucky and unlucky at the same time, but the lucky overrode the unlucky. The new building had the benefit of being able to convert regular pressure rooms into negative pressure rooms actually within a 10 to 12 hour period. And most of that was just validation that the transition had occurred. So we did have to shift where we were going to put any of the COVID positive patients. And it did dictate some of our patient placement aspects and change those fairly quickly. But from our existing building, the concept of the co-location would have been, which is something we were really striving for, keep the COVID patients together so that we, gain our experience. People are more efficient with the PPE, many different reasons. In the initial building, the negative pressure rooms were spaced throughout, so you wouldn't have been able to co-locate them. Luckily, in the new building, we were able to actually keep them all on one unit, keep the negative pressure going. And we've now built that into our plans moving forward, and work regularly with the facilities team to be able to go through and manage that. So we literally just look to stay 2 beds ahead. So when we get up to X, we will add X plus 2 and continue that process going forward. And that's easily met the demand of the increasing patient population for the negative pressure rooms.
Thanks so much. Neera, one question that came across, have you put in place any staffing or scheduling strategies to try to mitigate healthcare worker exposure or burnout? I remember one issue that we had in the emergency department when you mentioned that we were trying to protect residents from potential exposure. I, as a late 50s attending physician, found myself being protected by my residents who basically simply decided that they weren't going to let me into a room sometimes.
Right. Yeah, no, it's interesting how the dynamics are. We had this very complex, elaborate Excel spreadsheet that had every faculty member on for 1 week at a time. And then we had a backup person for them in case they got sick. I looked at Hany's ratio for a 500-bed hospital. He had 20 physicians. That's about 25 patients per physician. We had a much more forgiving ratio. I think we had many more physicians to help us plug into that schedule. So and there were physicians that became symptomatic, but fortunately tested negative. Part of it may have been just, anxiety around every sniffle that came around and just, wanting to get tested, but we wanted to be safe. So we were lucky. We did use fellows as well, and part of that backup list because they were board certified internists, they had completed residency. But like I said, we had so many people raise their hands to help. So we were fortunate in that regard.
Oh, thanks so much. Christina, we have time for one quick question for you. I get a lot of questions from folks who are wondering if we will have very, very highly accurate tests that don't involve what has been described as a brain biopsy. What are your thoughts on that? Can we anticipate a less invasive test in the future that has similar specimen collection characteristics?
Yeah, no, that's a good question. I think everybody, after they've had one nasopharyngeal swab, would rather not have another. So the various studies that have looked at the different specimen collection types, as you move away from nasopharyngeal, there's a slight decrease in sensitivity. So when you go to mid-turbinate, it goes down a couple percentage points, to anterior nares a couple more. And so you decide what is an acceptable, loss in sensitivity for the gain in people agreeing to get tested. And so now, with lower rates, more asymptomatic testing, there's a move towards, more anterior nares self-collected samples, as well as a move towards saliva samples. And so those are all acceptable because usually when you're doing that kind of testing, there's more repeat testing going on. And so if you do repeat testing with a lower sensitivity assay, you can make up for that loss in sensitivity. And just also the increased access to testing. And so there's the idea now that if you have more virus on board, that you're likely more contagious and more likely to have a positive test, even with something that may be a little bit lower sensitivity.
Thank you so much. Thank you all for participating in this session.